Section 4 will cover central nervous system pharmacology. We'll start with Chapter 1 on sedative, hypnotic, and anxiolytic drugs, and if you want, you could actually rename this chapter GABA type of drugs. In effect, what we're going to try and follow throughout that CNS review is some major neurotransmission, or at least some major type of effect in the brain. Right now we're going to be primarily excited about CNS depression in the first half of our review, and GABA drugs will include all of our benzodiazepines, barbiturates, and the alcohols. What do they do? Well, they cause a dose-dependent CNS depression. And when you look at CNS depression, it of course covers several planes of CNS depression. Anything from a mild CNS depression that could cause sedation, drowsiness, all the way to anesthesia that would require life support, or even respiratory depression, whereby you could have coma and death if the patient was not mechanically ventilated. The diagram shows you that benzodiazepines result in a CNS depression that tends to plateau. You see that it does not cause a linear relationship between the dose on the x-axis and the CNS depression on the y-axis. Barbiturates, on the other hand, and if you want to add to your notes ethanol, which is the common alcohol, well, barbiturates and ethanol, they actually cause a complete dose-dependent CNS depression all the way to coma, respiratory depression, and death. Now, we need to understand why is there such a discrepancy between benzos and barbiturates, especially when you consider that they are both working through GABA and its receptors. Before we leave this diagram, I do want you to notice one point of CNS depression. You see that the first level of CNS depression is called paradoxical disinhibition. Paradoxical disinhibition, in a way, is as if the patient was getting excited. You know, let's take a little note and let me show you some points that I would like you to be comfortable with before we look at drugs. Unlike in the autonomic nervous system, where we had a two synapse pathway with an efferent system that consisted of two neurons that were in series. In the central nervous system, the pathways are very complex, multisynaptic, with inputs left and right from all kinds of different neurotransmitters. Now, it is fair to remember that GABA and glutamate are the major neurotransmitters in our brain, whereas GABA is a major inhibitory neurotransmitter, glutamate is a major excitatory neurotransmitter. So if you want, let's draw here a GABA neuron, which then would tend to inhibit whatever follows. Let's also draw a glutamate neuron, which would tend to stimulate anything that follows. The issue would be what kind of receptors are sitting on these neurons themselves. Let's imagine, just for the sake of it right now, that here we have a GABA receptor, and here also. What would be the result of stimulating this GABA receptor? You're thinking of this? If you're stimulating this GABA receptor here, you are actually shutting down the production of this GABA neurotransmission. That is simply because GABA is always inhibitory. So you are now inhibiting an inhibitory neuron. What should be the endpoint? If there's no more GABA to inhibit, there's no more inhibition of what is downstream, and you end up with stimulation. This is what we call disinhibition. This happens when there are two GABA neurons in series. You might recall, if you've already reviewed that topic, that we see this very well in neuroanatomy, particularly in the neuroanatomy of the basal ganglia, when we study direct and indirect pathways. Well, a GABA on another GABA neurons would result in a stimulation, a disinhibition. Because GABA is so prevalent in the brain, often the first symptoms of a CNS depressant is to get excited. You might think of alcohol as an example. Most people drink alcohol without thinking that what they want to achieve is to become comatose and die of respiratory depression. They primarily drink alcohol in order to be more socially active, talk a lot, maybe say all kinds of things that they weren't planning on saying, and certainly have behaviors that are disinhibited. Contrast. On the second neuronal pathway, if I stimulate a GABA receptor, that would be on a glutamate neuron. then this GABA receptor is still inhibitory and as such will decrease glutamate production. Because glutamate was excitatory, you will lose that excitation. And as you lose that excitation, you will get depression. So a concept to have beforehand in the CNS is that being a CNS depressant may result in stimulation or depression depending on the neural pathway. By the same token, being a CNS stimulant will also potentially result in stimulation or depression. It depends also what you are stimulating. Well, let's go back to our PowerPoint presentation. And now that we understood the paradoxical disinhibition, let's see that commonly as we're going to increase the dose of the actual medication, we will see eventually depression with primarily a sedative effect of these medications, so we'll be able to use them in the treatment of insomnia. An anxiolytic effect by impairing cognitive function, that will be important for anxiety, panic attacks, and even a little bit higher dosages might result in less central impulses going to muscle with possibly anticonvulsant and muscle relaxing activity, so that we might be able to use these drugs in the management of epilepsy, also in the management of spasticity. Increasing the dose further brings us to a level of CNS depression where the volition, the will of the person is actually impaired, what we call hypnosis. It is once we get beyond hypnosis that now we need life support if we want the patient to survive and breathe by himself or herself under the influence of sedative hypnotic drug. From anesthesia onward, you really will depend on mechanical ventilation. So there is no doubt that even benzos can result in significant medullary depression, but this will generally occur when you take overdoses of these medications or in the presence of other CNS depressant. For barbiturates and alcohol alone, they can result in coma, respiratory depression, and death. To understand the mechanism of action of these drugs, we need to look at a GABA-A receptor. A GABA-A receptor is often referred to as a complex because it is made of 5 different subunits. These different subunits are classically given Greek letters, and by convention, the alpha subunit always represents where the endogenous neurotransmitter binds. GABA binding site, therefore, is on the alpha subunit. Commonly, these ligand-gated ion channels have 2 alpha subunits, so that normally they would require the binding of 2 neurotransmitter molecules in order to open the channel. The channel of a GABA-A receptor is a channel selective for chloride. Chloride in the central nervous system has a net force. Unlike in the periphery, chloride actually would be driven into the cell, and as it goes into the cell, it would hyperpolarize this cell, making it less excitable. Notice that then the other subunits are given other Greek letters, and depending on the arrangement of the other subunits, there are really a multitude of forms of GABA-A receptors. You may want to remember that drugs will then bind to these subunits and alter the way GABA itself recognizes its alpha subunit. This is what we refer to as allosteric modulation. In effect, the diagram is showing you that benzodiazepines, barbiturates, they do not bind where GABA binds to, they bind to their own sites on the GABA-A receptor. For instance, certain amino acid residues of the gamma chains of the ion channel are critical for the binding of a benzodiazepine, whereas certain residue of the beta chains are really the important ones for barbiturates to bind to. There isn't complete overlap of these binding sites. As such, the mechanism will show some slight differences, some variation between the drugs. Alcohol would also have its own recognition sites on this molecule. So recognize here that having 5 subunits offers just as many receptors for drugs to bind to. Let's check a little bit in the text some of the points that are written underneath that diagram. The GABA-A receptor is the one we just discussed briefly, at least as allosteric regulation would go from benzodiazepines or barbiturates or alcohol, and we know that the activation of this receptor increases chloride entry. Now, there are other GABA receptors. As a matter of fact, there are three: GABA A, GABA B, and GABA C. GABA B is one to remember also for the exam. GABA C is generally not board tested, but if you want to really know, it is another inhibitory receptor that is found primarily in the eye. A GABA B receptor, on the other hand, this is a G protein coupled receptor. And as a G protein coupled receptor, it still exerts an inhibitory action because through phosphorylation, dephosphorylation, it actually results in the opening of a potassium channel. This potassium channel will then leave potassium to efflux, and in such a way that you will still see hyperpolarization with GABA B stimulation. There will only be one GABA B drug to work with. It'll be the drug baclofen. So baclofen, we'll see, which is used in spasticity, will be the only GABA B agonist to be board tested on. All the other drugs that interfere with GABA that are board relevant will be GABA A type of drugs. Before we go further, could you remind me a receptor that actually would result in potassium efflux? You do find it in the SA and AV node, and it's important for the pacemaker current. Are you thinking the M2 receptor that is GI coupled? If you are, in our fundamental concepts of the antiarrhythmic, we actually discussed how G protein coupled receptors could alter ion channel conductance. And particularly, GI coupled M2 receptor could result in potassium efflux. Well, in a way, if you want, you could think of a GABA B receptor as if it was the muscarinic receptor. Let's look at benzodiazepines and go back to the GABA A receptor. You see that benzodiazepines are said to potentiate GABA. When you say the word potentiation, you should immediately think of a potential of a board question that would actually test you on the general principle diagram that are shown as log dose responses. You remember, these are diagrams that plot the actual dose on a log scale of a neurotransmitter or a chemical, such as GABA, and then that show you on the y-axis the percent response from this neurotransmitter, which here would be, if you want, percent CNS depression. What is the classic aspect of these curves? I know you remember, sigmoid type of curves. And if this was represented on the exam as the control curve, then the idea would be to show you other curves, maybe shifted to the right the same height, maybe a little lower, maybe shifted to the left, maybe a little higher. Label those A, B, C, D, and try and make you match the effect of a drug or a clinical story with these drugs. Well, where would you put your benzodiazepines now that you know that they potentiate the effect of GABA? I'm sure most of you, if not all of you, I hope, are thinking curve A. Since potentiation literally means now I would need less of GABA, a smaller dose of GABA than I would in the control curve to get the same response. So in a way, it would seem as if I gave more potency to GABA itself. Well, benzodiazepines would very much be board testable this way, and anything that potentiates would potentially show on this diagram. So once I know what potentiation means, then I may want to refine this a little bit and have an idea how do they help GABA give a greater response than it would by itself. Well, they do so by actually increasing the frequency of opening of the chloride channel. That increase in frequency is a very important wording to make it different from the barbiturates. In effect, what we mean by this in Pharm is that a benzo alone has no GABA mimetic activity. That is, when benzodiazepines bind to their sites on the gamma chains, they do not open the channel. They will depend on the presence of a neurotransmitter GABA to do its job. Well, if that's the case, we can now probably understand well why the benzodiazepines have a plateauing in their CNS depressant effect. In effect, really, we don't have enough GABA in our brain to cause CNS depression to the point of coma and death. And with a drug that has no effect of its own and only works through the presence of endogenous physiological GABA, there is just absolutely no way that benzodiazepines could result by themselves, certainly at normal doses, in significant risk for coma, respiratory depression, unlike what we'll see for barbiturates and alcohol. So, as mentioned earlier on, they are said to work through benzodiazepine receptors. These benzodiazepine receptors are part of the GABA-A complex, and there are two known subtypes of benzodiazepine binding sites, one that we refer to as a BZ1, one that we refer to as a BZ2. BZ1 receptors have been associated with the sedative effect of these medications, whereas BZ2 receptors are more likely associated with the cognitive effect of these medications. In the cognitive effect, the CNS depression is actually managing anxiety and panic by just dulling the brain of the patient. It is also this way that often we worry about impairment of such processes as memory. And we always worry about benzodiazepines potentially resulting in our behavioral sciences in anterograde amnesia. You remember the term anterograde? It means literally the actual drug will cause a problem with memorization simply from the time you take it and while you're under the influence of that medication. Obviously, the drug will not wipe out any memory processes that you've done prior to the actual administration of the benzo. It's only from the time of taking the benzo onward that we see this amnesia. If it is a side effect when you take benzodiazepines alone at home to manage your anxiety or your insomnia, certainly it can also be a use of these medications within hospital settings. Anterograde amnesia can be beneficial if we want patients to forget preoperative instructions or maybe forget simply some traumatic type of event that might be occurring while they're undergoing some exploratory procedure or while we prepare them for surgery. There is an important margin note in your syllabus. It relates to the drug flumazenil. Flumazenil is an antagonist of both BZ1 and BZ2 receptors. It blocks these receptors. As such, it can reverse the overdose of a benzodiazepine. Because barbiturates and alcohol do not bind to a similar site, flumazenil with zero efficacy cannot reverse the CNS depression of alcohol or barbiturate overdose, just that of benzos. Pay attention also to the drugs that we'll call zolpidem, zaleplon at the end of this chapter, because they are BZ1 selective agonists that can also be reversed in their intoxication levels by the drug flumazenil. Flumazenil, important BZ receptor antagonist. Let's contrast this to a barbiturate now. Barbiturates are not said to potentiate GABA, they're said to prolong GABA activity. And as they prolong GABA activity, we do not mention them as increasing frequency, but rather duration of chloride channel opening. Basically, once they bind to the GABA-A receptor, they keep the ion channel wide open. So the hyperpolarization will be greater than what physiology had expected. If that's not enough, highlight very well in your notes that barbiturates are actually GABA mimetic. And the higher the dose, the more likely the barbiturates alone will open the actual ion channel. And if it will open the chloride channel, then it means it's now only a matter of the dose of the barbiturate to see significant hyperpolarization. The risk of coma, respiratory depression, and death in barbiturate overdose is therefore a reality. They do not bind to the sites benzodiazepines recognize, so they do not act through benzodiazepine receptors. If you want to call their binding sites barbiturate receptors, well, that's fine with us. And surely, in a way, that's what they do, bind to their own sites on the GABA-A complex. They're already more toxic than benzos simply from the fact that they prolong the duration of opening and are GABA mimetic. You may want to remember from your biochemistry when you reviewed the electron transport chain that compounds like barbiturates can also block complex 1 of electron transport chain. So now as added toxicity, they can interfere with the ATP production of cells. And if you decrease ATP in a cell, you know just as well as I do that then sodium-potassium ATPase will not work well. Sodium will stay inside the cell, potentially causing hydropic swelling and in some cases irreversible damage. If this is a neuron, that we're talking about, which is a permanent cell that cannot divide, you could actually get irreversible cellular injury in the CNS depending on the dose of a barbiturate. It seems obvious then that barbiturates would be placed on the back burner as far as drugs that would be used for managing insomnia and anxiety. Benzodiazepines have now become our favorite for these conditions. You have a table that lists for you all your various benzodiazepines, and these are only a few amongst more than 20 different molecules that are marketed as benzodiazepine. They are always easy to recognize. They end up either in azolam or azepam. But when you look at this variety, how would you go trying to figure out which one to use for CNS depression that would fight anxiety, or for CNS depression that would find insomnia? Before we go too deep in this table, look underneath your table at the pharmacokinetic of benzodiazepines. Benzodiazepines, we've already mentioned in the general principles, are liver metabolized to active compounds. Look, I'm going to give you the example of diazepam. Diazepam is Valium. So I'm sure all of you are familiar with diazepam. Diazepam has more or less a half-life around 8 hours. It really depends on a number of factors such as the weight of a patient, the dosages given, and so forth, since CNS drugs are very lipid soluble. But really a fairly normal acting drug. Problem with diazepam is that through P450s, it's actually going to give nordiazepam. And nordiazepam has a half-life, no kidding, of about 60 hours. And if that wasn't enough, since nordiazepam is active and prolonging the duration of diazepam, nordiazepam in turn gets metabolized to oxazepam, which you know as well as I do, is actually one of our prescription drug, benzodiazepine. This also has a half-life which is close to about 6 hours. So you look at this all together. You put a patient on diazepam, you will see a prolonged effect of a benzodiazepine even in the absence of the parent drug diazepam, simply because now you're looking at the efficacy of the nordiazepam and oxazepam itself. So let's think in terms of anxiety management. Anxiety attacks, panic attacks can occur at any time of the day or night or be continuous. In this case, we would benefit from a long-acting benzodiazepine to have a CNS depressant coverage throughout the day, throughout the night, in the life of the patient. On the other hand, if you wanted to use that drug as a treatment for insomnia, well, imagine the sedative effect. You take a diazepam pill in the evening, and by the next morning, you would still be under the influence of the active metabolites. As such, you would feel groggy, sleepy. It would probably interfere with your function, and actually maybe that's one of the reasons you might be asleep in front of your computer screen right now. So wake up. Let's go back to our PowerPoint slides a little bit and then have an idea of the half-lives and duration of action of these drugs. Notice that there are 3 benzodiazepines that do not get metabolized significantly to active compounds. They're primarily conjugated and excreted as is. These include oxazepam, temazepam, and lorazepam. Of these, oxazepam and temazepam have a short half-life. These will be therefore very well tailored for insomnia management. Lorazepam may not give active metabolite, but it has a fairly long half-life, just from the parent drug alone. So because of this, we're more likely to use it for anxiety management. Really, you know, the shortest acting of all, if we go back to the table now, is the drug midazolam. This one, you could say in the indication that it is ultra short acting. We're talking here minutes for half-lives. So a drug like midazolam is a drug that can only be used in anesthetic protocol IV, particularly for preoperative sedation. Contrast in this table. Obviously, temazepam and oxazepam will be used for sleep disorders much more than anxiety because of their short half-life and lack of active metabolite. Conversely, drugs like alprazolam and diazepam and lorazepam will tend to be used for anxiety, panic, and much more so than they would be used for insomnia management. There's a final thing I want you to have ready by looking at this table. Which are benzodiazepines that are available IV? let's put them in bright red. You see diazepam, lorazepam, and midazolam? All three drugs here are available in IV formulation, allowing us to have a parenteral form of a benzo and therefore a stronger effect for that benzo. This is why possibly we could use these drugs in withdrawal states, particularly life-threatening seizures. So withdrawal states to alcohol or to overdoses of benzodiazepines abused as drugs, barbiturates, or simply for status epilepticus. My question to you would be, out of these three, which one would be a benzo that I would never attempt to use IV to curtail seizures in a patient? I'm sure all of you are yelling back at me, midazolam, and you are absolutely correct. If it is ultra short acting, by the time it would curtail a seizure, its efficacy would be gone. You turn your back and work on another patient in your emergency room, the effect gone would mean this patient would return to his or her seizures. So really, lorazepam and diazepam are the primary IV benzos that are used in management of seizures. And between the two, in the United States, we really prefer lorazepam over diazepam. You can imagine why. The kinetic of lorazepam is far more predictable, being that it does not have these long-acting active metabolites. Diazepam is kind of annoying. With a metabolite like nordiazepam that has a 60-hour half-life, you're never quite sure when the effect will be gone for that drug. Once you know this, you're really ready to put a few points about barbiturates. And as we look at barbiturates on this slide, we only remind you here that barbiturates are easily recognizable either because they're called something barbital or they're called something pental. We've put two of them here. Phenobarbital is actually very long-acting. Because it is long-acting, because there are also all kinds of formulation, including IV, it is primarily used in the management of seizures. Phenobarbital, for instance, we'll see in a subsequent chapter, is a good drug to use when a pregnant lady suffers from the disease epilepsy. Phenobarbital otherwise has been commonly used IM, intramuscular, for febrile seizures in children. Thiopentol, on the other hand, this would be an ultra-short-acting barbiturates. And just like the drug midazolam, because of that very short kinetic, it is primarily used to induce anesthesia. Well, pharmacokinetic of barbiturate is generally what puts these drugs on your USMLE step 1, or any step really. Not so much because through the liver they metabolize to active compound, but primarily because of the general induction of P450s they are attached to. As general inducers, they've often been used by board question as prototypes for what induction would mean. You remember that induction would mean a change in Vmax or Km. I know this is a biochemistry question, but since we're talking about enzyme, I'd better know a little bit about this. And induction means you having an increased gene expression, increased number of enzymes, and number, I put my little sharp sign here, so increased number of P450 should result in an increase Vmax. So you know the first thing we're going to do at this point is let's imagine a little diagram for a board question. And as I'm looking at this diagram, this time I'm going to use a diagram that is the famous double reciprocal plot. You would not believe how often I hear from feedback from your colleagues who took this exam the use of these graphics of biochemistry for pharmacology questions. Here you remember that we would put 1 over S, 1 over the substrate concentration, as a function of 1 over V, the speed of metabolism. These Lineweaver-Burke plot then represent enzyme kinetic as a straight line, and this straight line here would be the control P450 activity, you know, maybe such as 3A4, the most abundant type that we have in the liver. Let's not forget that then we read 1 over Vmax, where the curve crosses the y-axis, and minus 1 over Km, when the curve crosses the x-axis. Let's try and imagine what a barbiturate would do. Can you remind me what we said induction would do? Yes, barbiturates would increase the Vmax. Or let's take an example. Let's go from a value of 1 to a value of 2. then what would happen to 1 over V max? It would go from 1 over 1, which is 1, to 1 over 2, which is 0.5. So if this intercept here represent number 1, 0.5 would be below it. You would not change Km or the affinity, so draw yourself a curve that would be below the black curve, crossing the x-axis at the same point. Of course, I had another problem with cerebellar ataxia here. And as you're looking at this, you know this is induction, and that would be what would match the effect of a barbiturate on the cytochrome P450. As a matter of fact, this diagram could be matched for any other general inducers of P450. Do you recall drugs such as phenytoin, carbamazepine, but also antibiotics such as rifampin, and of course chronic alcohol, glucocorticosteroids? These are just as many inducers of P450 you could have matched to such a graphic. So once this is ready in your mind and you feel properly comfortable with these type of board question, let's look at the last point of my barbiturates here, which is the idea that they will be contraindicated in porphyrias. Yes, I know, this is again a biochemistry point, isn't it? And just to quickly review this together, since we could have used again this question with any inducer, let's check out another little diagram. Can you please help me and build heme? I kind of forgot how we do that. Look, we're going to take amino acids and we're going to take some glycine. We're going to add some succinyl coenzyme A. By the way, for your exam, who makes succinyl coenzyme A? If you said the Krebs cycle, make sure you smack yourself a little bit, not too hard though. Succinyl-CoA cannot come from the Krebs cycle. If it's an intermediate, it is neither made nor broken down by the Krebs cycle. It comes really from other compounds. We like to think of it as the vomit pathway generally in biochemistry. And if this is what your biochemist has used, well, then fantastic. If not, all I mean by this is V as valine, O as the odd carbon fatty acid, M as methionine, I as isoleucine, and T as threonine. So valine, odd carbon fatty acid, methionine, isoleucine, and threonine. That glycine and succinyl-CoA are combined together thanks to dialysynthase, the rate-limiting step of heme synthesis. This is a B6 requiring enzyme. This is the rate-limiting step. It makes diala or delta aminolevulinic acid, and as rate limiting, this is where the barbiturates exert their inducing activity. Barbiturates, when they induce cytochrome P450, must also induce the rate limiting step of heme, simply because all P450 enzymes, all of them, have a heme group. So there is no such thing as increasing gene expression of the P450 protein without inducing the actual synthesis of the heme pathway. Now, from delta alanine onwards, just briefly, remember that we dehydrate this to porphobilinogen, which I'm going to call PBL. And from porphobilinogen, we have a multitude of steps that will eventually lead to protoporphyrin, and from protoporphyrin to heme. All you need there is ferrochelatase and the addition of iron in order to make that heme group. Porphyrias are diseases that are associated with an enzyme deficiency within the heme pathway downstream from the dialysynthase step. In turn, it means if barbiturates would induce the activity of dialysynthase, they would in turn cause a buildup of porphyrins upstream from the enzyme deficiencies that porphyria patients suffer from. Therefore, they would exacerbate the disease. Well, as such, I want you to remember very well as a classic clinical and board point, any inducer of cytochrome P450 will be contraindicated in porphyrias. You know, one of the patients we most worry about is the one with the acute intermittent porphyria. That is because as an acute intermittent disease, that patient may never have been diagnosed with a porphyria. Thanks to the lack of chronic symptoms such as sideroblastic anemia, some bullous dermatitis, and so forth, or any coloring of the skin or coloring of the urine. Imagine what would then happen. We could actually trigger an acute attack of acute intermittent porphyria in this patient simply by administering a barbiturate, maybe to curtail anxiety or seizures, or using a drug like rifampin to eradicate Neisseria carrier state, or to treat TB, tuberculosis that is, or I mean you can imagine all case scenario with inducers. Well, we love to do this to you on the exam. By the way, acute intermittent porphyria, do you recall the enzyme that is deficient? Are you thinking uroporphyrinogen 1 synthase? If you are, perfect. Nothing to be said. You're ready for that type of board question also. So do not underestimate barbiturates on board question. Although they are less commonly used than benzodiazepines clinically, they certainly still have major point on the exam, particularly when it comes to cytochrome P450 induction and their contraindication in porphyrias. Here's another topic we need to discuss when it comes to central nervous system drugs. These drugs make people feel different. And if you feel different under the effect of a drug, you can be guaranteed that there is someone out there who's going to associate that feeling of difference with a pleasurable feeling. And as such will decide, you know what, I like this drug. I think I'm going to do it again and again and again, and then become addicted to it. Here, should we have a good reason to believe that there is abuse liability to benzodiazepines and barbiturates? Well, do you remember the third chemical we are going to have to talk about that also in part exerts its pharmacology through GABA? Indeed, it's alcohol. And we sure know that there is a big abuse potential to alcohol. So if there is such an effect of alcohol in the brain of patient potentially resulting in addiction, there is all reasons to believe that there might be exactly the same process going on with prescription drugs such as benzodiazepines and barbiturates. So as you look at your slide, you see that tolerance and dependence can result from sedative hypnotic use. Not only chronic use can lead to tolerance, there is very well established cross-tolerance between benzos, barbiturates, and ethanol. Understand by this, a chronic alcoholic will have a completely blunted response to benzos and barbiturates. It might mean in your hospital, if you had someone having seizures who was a chronic alcoholic, you may have to give this patient much higher doses than normal simply because they've adapted to the effect of alcohol already. They've become tolerant to it. So with that cross-tolerance, there is no doubt there is abuse liability to benzos and barbiturates. Actually, as you've seen in behavioral sciences, we can distinguish two forms of dependence to the drugs, psychological and physical. The way we know about dependence, if you recall, is when there is withdrawal from the drug. Psychological dependence is characterized by craving in the withdrawal. Remember, craving means the compelling need to look and find the drug in order to re-experience the effect of that drug. Physical dependence shows literally as an abstinence syndrome. And the abstinence syndrome, as being physical, can be measured through signs and symptoms. Generally, withdrawal to any chronic medication will result in the opposite effect from the drug. Remember that these drugs are CNS depressant. Therefore, what should you see in the abstinence syndrome? Are you thinking CNS stimulation? Because you sure will see CNS stimulation. Now, let's not forget who's most CNS depressant here. Ethanol and barbiturates are far more powerful than benzodiazepine. Let's not forget the plateau effect that we saw in that first diagram. As such, the abuse liability of benzodiazepines is always understood as less than that to ethanol or barbiturates. This shows well in the actual withdrawal signs to benzodiazepines. Most people who take therapeutic levels of benzodiazepines on a chronic basis will experience rebound insomnia, rebound anxiety on cessation of the benzodiazepine treatment. To see seizures with benzodiazepines, you would really have to have either a patient who used very high doses of benzodiazepine Or otherwise, not forget, maybe used benzodiazepine as an anti-epileptic. If there is a seizure pathology underneath the use of a benzo, there is absolutely no doubt that then benzo withdrawal would result in seizures. But generally, recall, rebound insomnia, anxiety, agitation are far more classic signs of withdrawal to benzodiazepines than the life-threatening seizures that will be the rule of thumb when someone on chronic use of alcohol or barbiturates would suddenly stop having access to the drug. Life-threatening seizures can be referred to as status epilepticus, and in the case of alcohol, they're part of what we call delirium tremens. And there is only one management. The management is to place the patient back under CNS depression. This is when we're going to use those long-lasting form of benzos. Can you remind me the two major benzodiazepines that could be used for that? I know you're saying lorazepam or diazepam, and I would always put lorazepam first for its more simple kinetic of administration. Of course, this does not preclude any supportive management of the actual withdrawal. Another major generality at this point in the chapter, there will also be important drug interactions in the CNS section, just as much as we have already seen in the cardiac section. Here, the major worry is that of additive CNS depressant effect between medication. You see, any medication that can inhibit functions in the brain, when added to another one, can result in more CNS depression. And let's not forget that the ultimate is the potential for life-threatening respiratory depression that would require life support, which of course you do not have at home. Now, what are the CNS depressants that would add on to the effect of benzo, barbiturates, or alcohol? Well, certainly in the hospital, when we use anesthetics, we actually take advantage of the additive CNS depressant effect, so that by giving smaller amount of various CNS depressant, we can achieve the planes of anesthesia. But the worries start primarily when we look at over-the-counter medication or other drugs that could have been prescribed by other doctors, other specialists to the same patient. Look at antihistamines. Antihistamines are classically over-the-counter, OTC, and as over-the-counter preparation, they're strongly sedative. Who has not felt that sedative and drowsiness effect of an antihistamine when you use them either as motion sickness pills or simply as medications that are part of cold preparations to dry your sinuses, for instance? Well, antihistamines are strong antimuscarinic drugs and as such are pretty strong sedative. They would be additive to the CNS depression of benzos and barbiturates. It is not unheard of that someone taking a benzodiazepine for insomnia, drinking a normal quantity of alcohol, if there's any such thing, in the evening, maybe to sleep a little better, but also suffering from a cold or allergies, taking an antihistamine, this person may not wake up the next morning. Think of famous cases such as the one associated with Heath Ledger. He was simply taking these type of medications and the use of a little bit of alcohol, none of which were in anything larger than therapeutic concentrations. The result was certainly dramatic. Opiates are normally prescription drugs. Now, we can never rule out a patient abusing opiates as street drugs. Nonetheless, opiates are very commonly marketed in the United States and very much prescribed for moderate to severe pain management in ambulatory patients. These opiates have been responsible for countless deaths from additive CNS depression. Let's not forget you don't need to be in the central nervous system as a drug category to have CNS depression as a side effect. Do you remember our drugs that decrease sympathetic activity, such as beta blockers, alpha-2 agonists, the famous reserpine, the famous guanethidine, all these drugs that could cause significant depression because they are CNS inhibitors? Well, as such, they would add on to benzodiazepine. Really, etc. would be a good drug to know if it were such a drug. But there are many drugs out there. Anything that causes sedation as a side effect, in a nutshell, would be additive to benzos or barbiturates. In forensic toxicology, this is literally the most common cause of death that is associated with drug interactions. Barbiturates otherwise, let's not forget, can cause drug interactions through the induction of metabolism. More to come about this when we talk about anticonvulsants. To end this chapter, let's look at different ways of achieving a sedative effect or an anxiolytic effect. These would be non-benzodiazepine drugs, and the group that comes to mind are what we love to refer to as the Z drugs. Not only zolpidem, zaleplon, but you may want to do yourself a favor and add the drug S-zopiclone. S-zopiclone is one of those famous drugs such as Lunesta that you hear about every time you put your TV on, makes you feel sleepy just looking at the commercial. So as you're looking at these Z drugs, these are BZ1 receptor agonists. How can you be a non-benzodiazepine and yet bind to a BZ receptor? Well, let me ask you. How can you be an alpha agonist and yet not be norepinephrine? Hey, it's exactly the same thing, isn't it? Phenylephrine, methoxamine, norepi, epinephrine, all these are just as many different chemicals binding to the same receptor. You can have no relationship to a benzo and recognize the same binding site. This is what zolpidem, zaleplon, S-zopiclone are all about. As selective BZ1 receptor agonists, they should only have a use, which is the treatment of insomnia, the treatment of sleep disorders, because BZ1 mediates a sedative effect. Since there's less BZ2 mediated effect, then there should be less effect on cognitive function. There would certainly not be anxiolytic. And based on the lack of BZ2 mediated effect, we are hoping that there should be less potential for anterograde amnesia. As mentioned earlier on, flumazenil is a benzodiazepine receptor antagonist. As an antagonist of BZ binding, it would also reverse the effect of an overdose to zolpidem and its family. Of course, meaning that the blocker can be used in situations of intoxication with those medication. Another advantage possibly of a BZ1 selectivity is having less tolerance and abuse liability than benzodiazepines do. I'm always mentioning possibility, or I'm leery of saying there would be no tolerance or abuse, because we know well in the drug of abuse arena that there is actually abuse to zolpidem family. It's just that it should be less addictive than benzos. Let's look at another drug that has nothing to do with benzos, the drug buspirone. Buspirone, actually a simple broad point is that it has absolutely no effect on GABA pharmacology. Indeed, this is a drug that works on serotonin. And as a drug that works on serotonin, it's a drug that is a known 5-HT1A partial agonist. Now, partial agonist, let's remember from our general principle, is going to be a drug that behaves both as an agonist by itself or as a blocker in presence of a full agonist. You remember, it results in these curve formats whereby by itself it has a slowing effect. In presence of a full agonist, it's actually going to behave as a blocker. So as such, it's a drug that has duality. The duality is very relevant here because when you look at a patient suffering from generalized anxiety disorders, you could understand that anxiety, agitation is too much stimulation. If it's too much stimulation, you'd like to give a depressant. But when you give a depressant, you're going to cause depression. And people with anxiety may suffer depression too. And when you're depressed, well, too much depression, you would like to actually give a stimulant. But now if you give a stimulant to treat the depressive mood of this dysthymia, well, now your patient is going to become too anxious. So it's either one or the other, or so it seems, until you think of a duality of a partial agonist. A drug that works on a serotonin receptor as a partial agonist can stimulate you with a slowing effect, so not giving you so much stimulation that you get too excited and more anxious, and at the same time, in situation where you have a panic attack, behave as a blocker without ever blocking the responses to serotonin completely and causing depression. This duality is excellent because with 5-HT1A partial agonism, there is no sedative effect from buspirone. However, Very similar to antidepressants, it will take 1 to 2 weeks for the effects. This will conclude our Chapter 1 of sedative hypnotic anxiolytic drugs.